Good afternoon and welcome to our Oak Bend Medical Center Happy Hour podcast. My name is Donna and I am your host. I am very excited to introduce our guest today as we speak about what to expect with an abnormal mammogram. Dr. Stephen Thomas is a board-certified general surgeon who specializes, but not limited to, abdominal procedures, benign breast disease and breast cancer, hernias, and thyroid surgery. He performs many of the abdominal surgeries laparoscopically, such as gallbladder, appendix, colon, and spleen removal, as well as hernia repairs. And he is also trained in a robotic surgery. Today, we're going to talk about breast abnormalities and what we can do about them. Dr. Thompson, thank you for joining us today.
Thank you for having me, John.
Well, today we're going to talk about the things women don't like to talk about, the scary things, and all those things. But first, I'd like to know, what is the difference between a general surgeon and a breast surgeon?
Well, basically, a general surgeon is someone who's successfully completed a general surgical residency. It's 5 years of training, which includes breast disease, breast surgery, breast cancer, but also includes multiple other types of surgery and diseases, including abdominal surgery, vascular, thoracic, trauma, transplant, things like that. So a general surgeon who completes their residency can go out and practice in any of those fields or all of those fields, whereas a specialist is a general surgeon who has elected to do only breast surgery or mostly breast surgery and deal with benign and malignant breast disease. They may have done some additional training after residency, which can give them more experience in dealing with breast disease and more focused in that area. But it's not anything different or more specialized than what you learn in a general surgery residency. So I think of myself as a breast specialist who continues to do other general surgical procedures and cases.
So, doctor, how long have you been doing breast surgeries?
Well, I opened my practice in 1991, so it'll be 30 years this year. And probably a quarter to a third of my practice has been breast related over the years. I've done approximately 1,600 breast surgeries, and that's not counting office biopsies and drainages and things like that. A while.
Very well qualified.
Yes.
So I received an abnormal mammogram. What's next? What can I expect?
So almost always with an abnormal mammogram, there's going to be some follow-up testing, either a spot compression view, which is a type of mammogram where they focus on a certain area of the breast that they thought looked abnormal and try to rule out, is this an area that's just overlapping tissue on the original mammogram that makes it look abnormal. And when they focus on that area, sometimes they can rule out a suspicious abnormality. The other very common follow-up test is an ultrasound. So one or both of those two tests are usually the follow-ups, and that will then determine if it's something that we can follow or something that may need a needle biopsy or that type of thing.
So there's a big amount of fear when you get an abnormal test. And sometimes it takes us a while to get where we need to go. There's one thing I know that's very special about you, and I want our listeners to understand that. You are very compassionate to women having abnormal mammograms or even anything that needs surgical evaluation. And my understanding is you try to get those patients in right away so that you can relieve that anxiousness for them.
Exactly. It's a very scary thing to hear that you have an abnormal mammogram, and until that gets worked up and figured out, women tend to be extremely nervous, and understandably so. And even if it's an answer that you don't want to hear, until you get a plan of action, I've seen many women be extremely nervous, and so my goal is to get an answer as quickly as possible and take care of the issue.
And that's commendable because that doesn't always happen. So thank you for being so caring about that. Now, I had someone come to me and said they have large breasts and they found a lump during self-examinations, but yet the mammogram came back negative. Should they be worried? What should they do?
So if they felt a mass and then had a mammogram that was unremarkable, they should definitely follow up with their physician, or come see me or another breast specialist. And most likely in that situation, we would do an ultrasound, obviously do an exam, but do an ultrasound as well. And then depending on, if the mammogram, the ultrasound, and my exam, I'm not too worried about it, then we're not going to just sweep it under the rug and forget about it and say it's nothing. We'll have a plan of action, maybe repeat an ultrasound and an exam in 3 months or something like that. But obviously, if we find something, then it's going to need that further workup with the spot fuse or needle biopsy or something like that.
So if you feel something's not right and you're really not sure, maybe follow up with a breast specialist so that you can get that peace of mind and fine. Tests don't always show something up. So if you're convicted, you need to go see someone else and get a second opinion.
Exactly. Don't ignore it. It doesn't make it go away, and it can only make it worse if you put it off.
So what is a biopsy? You always hear about breast biopsies and that. How are they done? Where are they done? It just sounds really scary.
So a biopsy is usually involves a needle of some type and a sampling of tissue, basically. So there's something called a fine needle aspiration or biopsy, where you're actually just collecting some of the cells from an area of the breast or a lump. And that's called cytology. The pathologist looks at those cells and they can make a diagnosis most of the time from that. A little more accurate, and what we use more frequently these days, core biopsy. And it's a little bit larger needle that actually samples the tissue and not just the cells. And that can give you a better idea of what you're dealing with. And those can be just guided simply by feel. If you have a mass that you can feel, but more frequently with ultrasound guidance to make sure that the needle's actually within your target. And sometimes with something called stereotactic, where it's based on a mammogram. It's not something that can be seen on ultrasound or felt, but using a stereotactic machine, basically, it calculates where to biopsy. So we can determine whether that's benign or malignant or indeterminate and needs further evaluation.
So we've determined a patient has breast cancer. What are the different kinds of procedures available today? What is it like? I mean, what can we do?
So if we come up with a diagnosis of breast cancer, the first thing that I like to do is get an oncologist involved, and we'll do a metastatic workup, which is designed to determine, hopefully, that the tumor is not spread, it's localized in the breast tissue. But whatever scans are done, a PET scan or a CAT scan and bone scans, will determine if it's localized or spread. And then depending on the size of the primary tumor, whether or not it's spread, different characteristics of the primary tumor, how aggressive it is, or if it's sensitive to, say, hormonal type therapy, different factors like that will help determine what the next step is. And sometimes that next step is starting with chemotherapy. And that can be to shrink the original tumor to make it easier to remove later on. When you start with chemotherapy prior to surgery, there's other reasons you might do that. The main concern with breast cancer or with any cancer is, are there cells out there that have escaped the main tumor and will later on show up as metastases? And so if you start with chemotherapy, then you have a better chance of knocking those cells out and preventing them from showing up as metastases later on. So, and if you did, on the contrary, surgery first, then you'd have to heal from the surgery, and that delays that systemic chemotherapy treatment and may give those cells a little bit better hold. A third reason to do chemotherapy first, and it's not in every situation, but if that's what's determined is needed, a third reason is if you have a tumor that's still in place, then you can see if it's responding to the therapy. Whereas if you'd remove given therapy and you wouldn't know, whether or not the therapy was effective. For example, you have a relatively large mass that would be difficult to remove with a lumpectomy, and you give neoadjuvant, that's the chemotherapy prior to surgery, neoadjuvant chemotherapy, and the mass grows or does not shrink, then you need to change therapies. It's not working. So that's one of the first determinations is whether we're going to do surgery first or chemotherapy first. We oftentimes will get a radiation oncologist involved, depending on the situation. But if it comes down to we're going to do surgery first, or we've gotten to the point where we're going to do surgery, the most common type nowadays is called a lumpectomy or a partial mastectomy, which is like a large biopsy. The goal is to just get a margin of clear tissue around the tumor. And most of the time that can be accomplished without having to remove the entire breast, which would be a mastectomy. Kind of the disadvantage for a lumpectomy or partial mastectomy is that you are then recommended to have radiation therapy to the remainder of the breast tissue. And doesn't have as many side effects as, say, chemotherapy, but it does take, a few minutes, 10 to 30 minutes every day, weekdays for about 6 weeks. So it's kind of an inconvenient thing, but most women do elect to do the partial mastectomy as opposed to the mastectomy. But if the tumor's too large or too widespread, or there's multiple tumors and we can't remove them with a good cosmetic result, then a mastectomy may be the way to go. And in that situation, most of the time we get a plastic surgeon involved and consult with plastic surgeon. If a woman elects to have reconstruction, that can be done at the time of the mastectomy, either with implants or with muscle flaps or different types of tissue. The plastic surgeons that I've worked with do an excellent job. Women are very happy with that.
That has really changed over the years.
It continues to evolve. And with the other part of the surgery for breast cancer, you're dealing with the primary in the breast tissue, but you also have to evaluate the lymph nodes. And when I was coming through residency, the only option was to remove all of the lymph nodes, and that was called an axillary dissection. But nowadays, almost routinely, we do what's called a sentinel lymph node biopsy, where we're sampling just a few of the nodes. And if those are negative, then it's been shown that the remainder of the nodes should be negative as well. So there's a lot less, surgery and invasion of the axillary tissue, and a lot less risk of numbness or weakness or swelling in your arm like there used to be.
That's good news. Good to hear.
Mm-hmm.
So I had a question from someone to ask you. For a woman who has implants, can they get breast cancer?
Implants do not change your risk for breast cancer. They may change your risk or increase your risk for a certain type of lymphoma, a rare type of lymphoma, but it does not increase or decrease your risk of breast cancer. The one thing in dealing with implants is that it does make it a little bit more difficult to do mammography or mammograms on a woman with implants, and some of the tissue is not seen as well as if you don't have implants, because the implant kind of blocks the view of some of the tissue. On the other hand, if you have an implant effectively stretches out the breast tissue over the implant, and so it might be easier to find a lump or something that's developed, some positives and some negatives there, but it does not increase your risk of breast cancer.
Dr. Thomas, is there anything that we've left out that you feel women need to know, or just know about anything in general about taking care of themselves and surviving abnormal mammograms?
Well, with breast health, I guess we could say it's important to do a self-exam. Obviously, you don't rely on the self-exam to try to diagnose breast cancer, but it's important to do maybe a monthly exam after your menstrual cycle and kind of get used to what you feel. And then if you notice any changes, then get in to see somebody about that and see if something, any further testing needs to be done, a mammogram or an ultrasound. Mammograms in general should probably start on an annual basis at about age 40 and continue for probably 20 or more years on an annual basis. But just realize that ignoring it or hoping that nothing's going to happen does not work out very well if something does happen. And not doing your self-exam and your annual mammogram, certainly not going to prevent you from getting cancer. So the more you keep up with it, the earlier you can catch something. And if you end up with a cancer diagnosis, obviously the earlier you catch it, the higher chance you have of treating it successfully. Most women, with annual mammograms are diagnosed early and basically cured.
Okay. Genetics plays a big part in breast cancer. What about the generational breast cancers that we have in families who may have daughters? Is there an earlier detection for them? Is there something we can do for them?
So if there is a genetic test that if you see a family cluster, then you may do the BRCA1 and 2 testing to see if your family is at increased risk. And there is increased risk if you have family members with breast cancer. But even if you don't have breast cancer in your family, that does not mean that you will not get breast cancer. The majority of women that get breast cancer have no family history of breast cancer. But women who do have a strong family history should talk to an oncologist and evaluate whether or not their family should be genetically tested.
Okay. This has been some valuable information today, and I think it's very important to know that, you shouldn't stall on this. You need to have your exams. If you think you felt a lump or you've had an abnormal mammogram and need further workup, you need to go to a surgeon, one that specializes in breast. I have to say, Dr. Thomas is very compassionate, very open, and sympathetic to women and getting their information that they need to get in a timely manner, because it is a lot of anxiety to sit around and wait for an exam. I want to thank you, Dr. Thomas, for joining us today. And a big thank you to our listeners for tuning in. Beginning now, set an intention and a relentless focus on living your life as the greatest person you can be in all situations. For all you women and men out there, make sure that you're doing your exams and take care of you. Please join us next week.
Thank you for joining us today on Oak Bend Medical Center Happy Hour podcast. We hope you enjoyed today's broadcast and invite you to email us at oakbendhappyhourpodcast@obmc.org with any questions or topics that you would like for us to cover. Remember, you can find us here each Friday at 5. Until next week, be mindful and stay healthy.